Hello, I'm Dr. Robert McMullen. I'm a psychiatrist. I went to Georgetown Medical School, which was a really nice place, and I went to Columbia Presbyterian for my psychiatry residency, which was also excellent. I've been doing mainly psychopharmacology, treating patients with medication for over 35 years. And the question that I'm being asked is whether there's any specialist psychiatrist such as for depression. We do have a lot of specialties. We got some psychiatrists that specialize in addiction, some that specialize in forensic. We have child psychiatrists. We have geriatric psychiatrists. So people often have a specialty. Sometimes it's a subspecialty that they only practice part of the time, and otherwise they treat adult patients just like all other psychiatrists. Now, all psychiatrists treat a lot of depression because it's such a common disorder. But there's many psychiatrists that are very specialized in it. It's a big difference if you compare a psychiatrist who sees patients for 1 hour and does psychotherapy and sees the patient once a week, from somebody who just focuses on getting people better from their disorder and sees people for a briefer amount of time. The doctor that sees people for an hour and perhaps sees them once a week, he might only have 40 patients. How much experience do you obtain from that if you're treating also schizophrenia, panic disorder, obsessive compulsive disorder, major depression, and a few other things? Whereas somebody who just focuses on the psychopharmacology, like me, once I've got people doing well and stabilized, then I start seeing them every few months. There's no reason to see them more frequently unless I just wanted a cash cow. And then you accumulate a lot of patients. So you might have 600 or 700 patients, and then you have a lot of experience with psychopharmacology. Now, it's also important that the psychiatrists go to conferences and learn new things, and that he read the journals, and that he talk with colleagues, and if he has a patient obtain a consultation with another psychiatrist, that he learn from that psychiatrist. Learn a different way of looking at things or learn something new. If people keep doing the same thing all the time that doesn't work, then they're going to keep doing things that don't work. For example, I had a patient who come to me who was for 20 years having recurrent depressions. And each time that she had the depression, she would go into it abruptly over a day or two. The depression would, and then she'd be very agitated and talk a mile a minute and complain that she's going to lose her husband, she's going to lose her job, everything's falling apart, she can't think, she can't concentrate, she can't keep up with her work, people are going to notice, and saying the same things she said in every depression for 20 years. And then, after a few months, in 2 or 3 days, the depression's gone. And when the depression is gone, she tends to be a pretty energetic woman. And is involved in a number of things, as if she's slightly more energetic and a little higher than most of us. And so I wrote a letter to the psychiatrist, and I said, you know, this lady's been on this high dose of an antidepressant for years, and she's on it whether she's in a depression or she's not, and we don't know if it's working or not. And also, it could be making her worse because the symptoms she has are consistent with being somewhat bipolar. When depressed, she's not in a retarded depression where she's talking slow and has no energy and can't do anything. She's got all this energy. She's on the phone complaining, she's talking fast, thinking fast, and also she goes in and out of the depressions abruptly. those are all bipolar signs. So the antidepressant may be causing her to cycle. She may be having 2 or 3 depressions in a year when she might have only 1 if she weren't on it. And she should be on things that work as antidepressants but aren't called antidepressants, like low-dose lithium, low-dose Depakote, lamictal lamotrigine in a regular average dose, and fish oil. And there's other things that help. And then the doctor calls me up and he says, oh, and I also sent a couple of papers. I searched around and I got some papers describing this bipolar spectrum type of patient who might have a mixed state where they're both depressed but hyper and like they're a little high at the same time. So I sent him a couple of papers describing all this, and he calls me up right away and he says, no, she's not bipolar. I've been with her 20 years and I've never seen her high. I've never seen her high once. You know, he completely missed the point. And there's a lot of psychiatrists that are like that don't see, especially bipolar disorder, and a lot of times attention deficit disorder. I've had a lot of people come to me for some major problem like a big depression or bipolar illness, and then 6 months, a year later, it finally occurs to me to ask them about attention deficit disorder, and I find out that they have it, and then I give them a stimulant like Ritalin, methylphenidate, and suddenly they're just functioning much better and start getting promoted at work. But it's something you have to think about to ask these things. There are psychiatrists that specialize in depression. Now, a lot of us are self-identified. We don't have a separate subspecialty with boards or anything. We identify ourselves as specialists in depression and perhaps all the other major illnesses like schizophrenia and manic depression too. And hopefully we're going to conferences a lot, reading journals, learning from other people, and trying a lot of things. It's very important to have as a goal that you get the person completely normal, because a very large proportion of people do well on an antidepressant or whatever, like Wellbutrin, bupropion, or Prozac, fluoxetine, but they're only at 80%. They're still not enjoying life that much. It's hard to concentrate at work. They're a little lethargic. They don't have a lot of energy. But they look normal to everybody else, and they're functioning, and too often the doctor's satisfied. They have the patient up to the maximum dose the patient can tolerate, and maybe they've gone higher and it didn't help any more than at this dose, so they're at this dose, and then they just keep refilling the prescription. But you should have a goal of bringing the person completely to normal. Now, sometimes that involves just adding a different type of antidepressant. There's many different options. Some of them are not medication oriented. For example, exercise is just a major thing for depression. And there was a wonderful study where they put half of people with serious depression in a gym, and they had a trainer stand over him or her and make them do all these different things. And then they put the other half at the same time of day across the hall in a yoga classes. And the people that were in the exercise room had a dramatic antidepressant effect, and the yoga people didn't. They found out that the dose should be 5 hours per week, and split up, not all in one day. And the minimum dose to get some antidepressant effect is about 3 hours per week. Now, you might be able to do it with just a half an hour if you did something really vigorous, like running up and down stairs or something. And if you're doing something that's not vigorous at all, such as walking, then you might have to do it a little longer, like 2 hours or 3 hours per day. But if you're really depressed and you're not working for whatever reason, then you should put all that time to use and do the exercise. Now, because I have all this experience and because I've tried so many things, then I frequently do get people to be 100%. And it's hard to really push these things unless you've had the experience of them working. And I'll list them briefly. Doing all this exercise, getting on a special diet that's more like a vegan or Mediterranean diet, taking adequate vitamin D, taking fish oil, and there's some other nutrients like NAC, N-acetylcysteine, inositol, probiotics, and I'm leaving out a couple. But with all of these, I've got dozens of people who've really responded, and I have quite a few people who've been on them for years and they're really working, and if they stop them, they either immediately get depressed or maybe a week or two later. And then we put them back on and they come right out of it. So these other things that are basically foods or nutrients or exercise really do work. But much of the time when you try them, it takes a few trials with different people before you hit a person that it works really well. And since I've had it happen so often that I have gotten people out of depression or the rest of the way out of depression with these things, then I don't give up. I keep trying them. But many other people that haven't used them that often, they try one of these things a few times and it doesn't work, they just don't feel that excited about it. There's other things that also one should try, such as MAOIs, MAO inhibitors. These are the strongest antidepressants, and it's surprising how many psychiatrists have never used them because they're a little bit dangerous. If you eat cheese or something, your blood pressure can go way up. But sometimes you just have to use them if other things aren't working. Another thing that should be done is to push people to do more psychotherapy, especially cognitive behavioral therapy, and also this EMDR. There's some research indicating it may work just as well as CBT for depression, but there's extremely strong research that it works well for post-traumatic stress disorder. And the Veterans Administration recognizes it as a valid treatment for this. And it works faster than other treatments for. And then there's a lot of patients who keep failing on medicines, that the medicines work for a while and then they poop out, or they don't work at all. And then they try one medicine after another. If it's not working, you should throw it out. Maybe 10% of us have chronic depression or recurring depressions, and we struggle with depression during our life. But of that 10%, maybe half of us are a little bipolar. And even if it's hard to find that the person had highs or they were very mild highs, it doesn't matter. If their brain chemistries are a little bipolar, then they're a little bipolar. And then if you switch them to other medicines like lamictal lamotrigine or very low dose of lithium or low dose of Depakote or fish oil and a few other things, then you often have really good success. But it may take some months. And you have to have had the experience of waiting and going on these things and the person gradually getting better, because it doesn't always work that you just take people off antidepressants and put them on what are called antidepressants and put them on other things and that they're going to be better in a month. Sometimes with a regular depression, especially if it's intermittent and they haven't been chronically treatment resistant, you can put them on a standard antidepressant like Lexapro, Lexapro, Zoloft, and so on, and in 15 days they're doing much better, and in 4 to 6 weeks they may be close to normal. And those patients are easy to treat, unless they start pooping out and the antidepressants stop working on them. But it's the more difficult cases that you have to start thinking of other things and using a few things at once. And it's best to add one thing at a time, and if something helps, then you leave them on that. And then go and add something else. If something doesn't work, you stop it. And then it takes some educated guessing about what to do next. Plus, you have to have a good relationship with the patient and consult with them about it, about what you think we should do. And then if they have some real objection that they don't want to take any chance that they're going to lose any of their hair, it grows back actually if you take something and cause it to lose, or to gain any weight, then you'll just avoid the medicines that could do that, or you just use them in lower doses. And anyway, in conclusion, there are people that specialize in depression and spend a lot of time thinking about it and thinking about their patients and trying different things and different combinations, and they get a higher proportion of their patients all the way to normal. And another thing that we add is we add TMS, transcranial magnetic stimulation, and that's painless usually, and you just come in, spend half an hour getting the treatment, then you go to work or go to school. And that's another modality that can be added on to the medication. And this has been Robert D. McMullen talking about finding and using a psychiatrist that specializes in depression.
Thank you very much, Doctor.